this reticular pattern indicating that it was superficial and had come on later. That's the only thing is to remember from this slide is that flat lesions tend to have arrived later on. So they're also called Clark nevi, and they're more common on the trunk than elsewhere. They can be any colour from pink to black, and they mostly are a nice sort of roundish oval, but often they're rather odd shapes as well. And the histology is atypical the bigger the lesion. So the bigger it is, the more likely you'll get an atypical report. It doesn't mean the more likely it's melanoma, not at all. And they have strong junctional component on histology. They may have a little bit of a superficial dermal component, but it's not a deep dermal component. Now, nevi in some sites of the body look different from other sites. And for example, I'm not talking about this, but nevi on the ear have their own characteristics. Nevi in genital areas have their own characteristics. On the nipples, they have their own characteristics. But important to think about is facial nevi because of the number of adnexal structures. So that's hair follicles and sweat ducts on the face is huge. And the pigment often spares those adnexal sites, meaning they have little gaps between the pigment. And on the palms and soles, we have ridges and furrows. And the normal pattern of Nevis cells is to line up along the furrows. So, dermoscopy, little gaps. It looks like a reticular pattern, but the reticular pattern is made up not of the waviness of the retes, but by the gaps due to sweat ducts and hair follicles. And on the palms and soles, we see parallel lines much more frequently than intersecting lines. So, which of these nevi is on the face? Okay, so everybody's got their white one up because we can see the white holes, but we can also see lots of dots and fine hairs. And this one is on what side of the body? Palm or sole, absolutely. We know that because of the strong ridges that we see. On dermoscopy, the facial nevus has these regularly dispersed gaps where there are adnexal structures. And on the sole of the foot, we have prominent pigment in the furrows. Now, sometimes there is a little bit of pigment going across, forming a bit of a lattice. But the intersecting lines tend to be a bit more like a brick wall, like that, as opposed to like that. So it's called a lattice pattern. And you would not be considered correct to call that a reticular pattern. On the sole of the foot, there are on the palms, there are lots and lots and lots of sweat ducts. And this is a dirty foot. And that photograph is to show you the distribution of those sweat ducts. They're in lines. And they're on the ridges. So the sweat ducts are on the ridges. So if we follow that along, it's on a ridge. This is a completely benign nevus, but it's a variant that we'll deal with in the advanced class. Now, nevi is often taken off, and if you shave off a dermal nevus, which is a frequent clinical scenario, somebody comes along and says they don't like their papillomatous or dermal nevus, so you shave it off. You will leave some behind, and within the next 3 months, it's very common that pigment will occur within the scar, and that's called a recurrent nevus. And sometimes it looks really bizarre, like that. So that particular patient, that was a breast nevus. She had had 2 removed fairly recently by a doctor somewhere. So I said to her, what was the pathology? And she said, sorry, doctor, I don't understand. So I rang the GP and asked him what was the pathology of these lesions, because I had to make a decision whether they would be re-excised or not. And he said, well, they were just harmless moles. I didn't get pathology, I just threw them in a bucket. So don't do that. It is considered malpractice, and you will be up in front of the disciplinary people if you remove a melanocytic lesion knowingly and don't send it for pathology. So every time you excise a mole, send it off. Now, people say, but I took 10 off. And my first question is, why did you take 10 off? And my second question is, the point is, you're not very kind to the pathologist, they only get one fee. Whether you take 1 off or 10 off. So they won't be very pleased with you. But you do need to send every single specimen off to the lab, because what happens if that's the result? So that patient did have to have re-excision done of a benign process. Now this one was the history of an atypical Nevis that had been excised, and this regrew. And that was excised too and was melanoma. So what had happened was the diagnosis was incorrect. The original lesion was a melanoma. And recurrent Nevis could be after laser ablation, which should not be done for nevi unless you really know what you're doing. So we have a bit of a problem at the moment with hair removal, because the hair removal lasers include the neodymium YAG lasers that will destroy melanocytic lesions, and they come back looking like this and are very, very difficult to assess. So not a good idea. Which of these is a recurrent Nevis? I'm hoping you can see scars. Both of them have got scars. I'm finding this one a bit tricky. Some people are taking their time to do it. We've got whites coming up and oranges coming up and both coming up. So I'm going to ask Anna. She says, Anna, what do you think? Can you see the scars in both of them?
Yeah.
Okay, so...
And I said the A.
Mm-hmm. Yes, you're correct.
Oh, okay. So I'm confident about that now. No, I'm not actually sure why. I think because B looked like it was very regular, and I can't explain why I said A.
Okay, so A, we're seeing a roundish scar, which probably means it's been shaved off. And the pigment is irregular in shape. It's sort of fairly uniform, and apart from that. And it's within the scar. So it's within the scar. Now this scar has a pigmented lesion coming up on the edge. Now that's a bit of a surprise if it was a recurrent Nevis, because we would expect it to come up in the middle of the scar where the dermal component is. So the first thing is that's not likely to be recurrent Nevis. So we have to think of something else. What else might it be, do you think, Anna? If it's not a Nevis, what might it be?
Angioma.
Angioma? Yeah, maybe. If it's brown. Melanoma? Could be melanoma. In which case, I wouldn't agree that it was even in colour and structure. So is there a test that you'd like me to do? Dermoscopy. Okay, so let's do the test. So the recurrent Nevis looks a bit more peculiar on dermoscopy, and it no longer looks uniform. It is confined within the scar, but we've got lines, we've got clods, and they're not uniformly distributed. So although this is an entirely benign process, it sure doesn't look it. And this is a melanoma, which is also disordered. So recurrent nevi recur within 3 months and recur within the scar. Recurrent melanoma can occur at any stage and maybe not within the scar. So this might be 3, 5, 10 years later. Or it might be coincidence, might be nothing to do with the original lesion. Both of these are clinically worrisome, and the management is excision with a 2 mm margin. So this needs a full thickness excision, and so does that. Now if that looked pretty harmless looking, we might just say, oh well, come back in another 3 months and we'll take a look. Eventually the pigment does fade from recurrent benign nevi, and eventually you would expect this melanoma would be bigger, but we didn't wait, we cut it out. And the histology was melanoma for this one, but it might not have been. Wouldn't help me. Now, just a few more nevi that occur in childhood. A Spitz Nevis, a Reed Nevis. So a Spitz Nevis is an odd-looking mole, and it's usually solitary, so they look different. And they can be pink or they can be dark, and they can be flat or they can be papular. But they look different from the child's other moles, and we would expect them to be referred to a pediatric dermatologist, or if you don't have a pediatric dermatologist, a dermatologist for assessment.
When you say they may resolve, what time period would they resolve?
Years. So some of them we watch and some of them we excise. The difficulty is melanoma in childhood is usually of a spitzoid type, so you don't want to get it wrong. Melanoma in childhood is extremely rare, but it still occurs. So
and that would come on to come into the lesions developed.
They grow. So the patient or the parent brings the child with the Spitz because they grow very rapidly, and they're very obvious. They're usually on the face, which just makes them fairly obvious, and they look quite different from anything the parent has ever seen before because they're uncommon, and they're very weird looking, but they are benign.
I removed a mole from an 18-year-old girl's leg that was reported as a Spitz Nevis.
Yes.
And she died from the melanoma 3 years later.
So that was misdiagnosed.
So should I be worried that my one that they rang up and said, I think it's melanoma, and the next week they said, no, it's definitely a Spitz Nevis, don't worry about it.
There were 2 lectures in the Vienna conference on Spitz nevi, and I'm not sure at the end of it or in fact 3 lectures really. They're very uncommon things, and they're very difficult to evaluate clinically because they're solitary mostly, and they grow rapidly, and you don't want to be wrong. And they mostly occur in children, but sometimes they occur in adults. And then this type of melanoma called a spitzoid melanoma is called that because it looks like a Spitz Nevis. So we get a bit scared. The facts are that melanoma in childhood is very rare and Spitz nevi mostly in children. So if you've got a 4-year-old, it's pretty clear, it's benign. If you've got a 40-year-old, it's pretty clear you're going to cut it out. The 18-year-old's much more difficult because are they a child or are they an adult? And that's tricky. So the outcome really of this discussion in Vienna was if they are flat in children we watch them, and in adults we cut them out, and if they are papular we'll probably cut them out even in a child. But the reasons for that are not medical, they are philosophical, psychosocial and other. And don't believe the pathologists, as we've just heard. They don't know. They don't know. They go on the architecture. So the architecture, if it's very sort of benign looking, like here we have a nice architecturally benign looking papule. Same under the pathology. The architecture's benign looking, it's benign. But it's not easy. So you have to take it on an individual case, and in primary care I would certainly shift the blame to secondary care. Don't do the surgery yourself, refer on. We have a weekly MDM on all the pathology that's unusual. Any spitzoid tumour we'll definitely see in our MDM. The any melanoma diagnosed in anybody 18 or younger must, according to the standard, be discussed in an MDM. And that's one of the reasons, because it's really hard. And they'll usually send the specimen to Australia, to the melanoma panel. And they often come up with stump. Anyone know what stump stands for? Acronym STUMP means the pathologist stumped, but it also means spitzoid tumour of unknown malignant potential. And another thing that I learnt was never ever do a sentinel node biopsy in a child with a spitzoid tumour or a stump. The reason is Spitz nevi are found in the lymph nodes. So if you go and have a normal Spitz nevus like this one, and you do a lymph node biopsy, you're going to find Spitz cells there, because that's what they do, they go there. But that doesn't mean it's cancer.
So can I just ask maybe a fairly obvious question? Is the Spitz nevus, is the spitzoid malignancy does not come from a Spitz nevus? Is that right?
A Spitz nevus is a particular kind of melanocytic nevus. A spitzoid tumour is a particular kind of melanocytic tumour. But it's just term, they're just words. There's benign, malignant, and don't know. So there's malignant spitzoid tumours, there's benign spitzoid tumours, and there's don't know spitzoid tumours. And if it's a don't know one and they're a child, they'll probably survive. If it's a don't know one and they're an adult, they probably won't.
Is that originating in the dermal layer?
You have superficial and deep ones. They're dermal, yes, but they can involve the epidermis. I don't really want to talk anymore on Spitz because they're really uncommon. We've got a lot of other stuff to cover. But they have nice dermoscopy with clod pattern, which is either red or pigmented. And this kind of called the reed, like a blue nevus, is deep in the skin. And they tend to look a bit like a blue nevus, but they're blacker. And a benign, that's a spitzoid melanoma. Okay, so we had a Spitz benign, and this is a Spitz melanoma, and there ain't much difference, right? So the message is, do not handle Spitz, refer on. Let me deal with it. Okay, so atypical pink lesions. Children refer to an expert. They're likely to be monitored. They may be cut out when we get nervous enough. The risk of melanoma is very small. The pathology is very difficult.
What would be your typical pink lesions?
Oh, benign melanocytic nevi in a pink person. Have we got any pink people here? Pink hair, you know, red hair, blue eyes, that kind. They have pink moles. So they're hugely common. Normal moles with no melanoma. Adults, we're more likely to cut it out, more likely to have melanoma, and it's still difficult pathologically. Because let's talk about more common things, shall we? The signature nevus is the type of mole that most people have. So if you're fair-skinned, you'll have more moles than if you're dark-skinned. And some dark-skinned people have very few moles. They might only have one or two, but very uncommon not to have any. And fair-skinned people tend to have many moles that look the same as each other. For example, they might be all brown, or all pink, or eclipse, coccard, lentiginous, and perifollicular hypopigmentation. And at first you might think, ooh, because your patient's gone up like this, you know. This is okay, doctor? And you go, oh, that looks a bit dodgy. But actually, if you looked at the rest of them, you'd realise that it's just one of a kind. So in order to make that decision, you've got to do a full skin examination. So we get referred quite a lot of eclipse, coccard, lentiginous nevi because the person has not examined the rest of the skin and they've just thought that's a bit odd. But it's not odd in that patient. We'll come to that. We come to that. So the patient with many nevi tends to have 1, 2, or 3 types of nevi. So they might have all brown, or they might have some brown, some pink. And it is said that you can tell the number of nevi best by looking at the upper arm. And moly people tend to be moly on the upper arm. So if you're in a hurry, and the patient says, "Oh, while I'm here, doctor," and you go, "Oh, we've already dealt with the pill and this and that, you know, you've already done 5 things," and then they say they want a skin check. You just look at their upper arm and you say, "Yes, you definitely need a skin check. Please book in." Or you look in their upper arm and you see nothing. You would say, "Is there just one spot? You know, we've probably got time to just look at one spot. You know, you've got one," and so you can go from there. So solid brown means they're brown. Solid pink means they're pink. Doesn't mean the size or anything. So, but it would. Somebody with a mole like that's probably got dozens and dozens of flat brown moles. Or if they've got very large ones, they've probably got several large ones. On dermoscopy, the brown one is brown, and the pink one hasn't got any pigmentation. So you can't say whether it's reticular or globular because there's no pigment. So we have to go on what do the blood vessels look like. And pink nevi have either the dotted pattern of vessels, or they have the curved line pattern, like that. And if it's dotted, it's vertical vessels, and if it's comma, it's horizontal. But that doesn't really matter. They're uniform. So the pattern is red dots of this one, and the pattern is brown structureless. So the eclipse nevis is an annular nevis. We have the sun going across the moon. And that's interesting. Let's have black. So here we have an eclipse nevis. And it's got 2 components. It's got the outside component and the inside component. You could have a partial eclipse. It's still an eclipse nevis, okay? But it makes it now not symmetrical. So an eclipse nevis loses its symmetry, but it's still an eclipse nevis. It's still absolutely benign. So knowing that pattern is useful, so that you don't refer people saying that that's not symmetrical, because I'm just going to say, yes it is, it's just missing a bit. And you can actually also have interruptions, like that. The Coccard nevis is seen in the same people. So people who have eclipse nevi have a Coccard nevis too. And it really just means that it's got another bit in the middle. On dermoscopy, the outside bit is reticular because it's the more superficial component. So if you looked at your mole from sideways on, you've got your dermal bit. No, I've drawn it wrong. So you've got your dermal nevus here, but it's also got shoulders of junctional. So it's got a papule in the middle and a flat bit on the edge. So the edge is lines and the middle is structureless. And the fact that the Coccard has another middle just means it's got a pigmented bit in the middle. Okay, Coccard means we know that at least one person in this room doesn't know, who's fessed up to not knowing. Okay, some of you are playing the game anyway. That is a cocarde, and it's a ribbon that is made up of a knot of ribbons, usually more than one colour. And it was used to put on the hat of the soldiers in the 18th century. So if you were in the French, you had red and blue and white, of course, to be in the French army. But if the German army was getting paid better, you could always just swap your ribbon for one of those dead people on the ground, you know, and take their ribbon, put it on your hat, and then go to the other army where they got paid better or better food or something, because they didn't have uniforms in those days. So a cocarde is basically concentric rings, and a cocarde Nevis is concentric rings. And it's always the lines on the outside, a structuralist zone next, and in the middle it can be structuralist or it can be clods. So two more types of signature nevi that are not uncommon. The lentiginous. These are little dark spots, and people are covered in little black spots. And when you look closely, the centre is darker than the edge, and they often have a little bit of scale on them. And the perifollicular hypopigmentation pattern is that there's hypopigmentation around the hair follicles. And on dermoscopy, the lentiginous one, dark centre, and a little bit of a radial bit coming out, and the perifollicular hypopigmentation. So the hairs are relatively less pigmented than the non-hair bearing skin. And people tend to have many of those together. So you might have lots of brown nevi, lots of pink nevi, half a dozen eclipse nevi, and 2 cocarde nevi. Or you might be somebody who goes for the lentiginous pattern and has hundreds of little black spots. We get a lot of referral for lentiginous nevi, and I'm nearly always puzzled, and it goes like this. The patient comes for, well, we actually don't, we do an imaging clinic rather than a face-to-face clinic, but the patient comes with this letter saying, I'm worried, from a GP saying, I'm worried about the spot in wherever the location is, let's say right hip. And then we go to the right hip and we see dozens of dark spots, and we ask the patient, which one was your doctor worried about? And they say, I don't know. So that would suggest that it was, again, the sort of pull up of the shirt, is this okay, doctor, problem? Examine your whole patient. Perifollicular hyperpigmentation occurs in the congenital type. Okay, so Bruce is telling me I've got to wrap up for lunch. We come back to this atypical thing. Atypical nevus. Well, there isn't such a thing. It's either benign or it's a melanoma. Atypical Spitz nevus, either benign or melanoma. The stump I've already dealt with. Meltump, melanocytic tumour with uncertain malignant potential. Sampas, superficial atypical melanocytic proliferation. Basically, it's either benign or it's malignant, or we don't know. And this sort of patient is the don't know one. He died of melanoma, maybe it was that one up there. He'd had multiple melanomas excised, and goodness only knows how many were left on his skin. Dermoscopy didn't help that much, actually, because most of his moles looked horrible. But digital dermoscopic surveillance might have been helpful if he hadn't died, because we would have been able to pick those that we're changing. Okay, sometimes it's easy, sometimes it's difficult. Which is benign? Not easy. So that one was uniform and is a compound nevus, and that is not uniform. So the not uniform, the loss of structure is helpful. Right, well, those two are both melanoma, just to make life difficult. And we'll deal with melanoma later. Thank you.